The clinical success of dental implant relies entirely on osseointegration, the complex biological process where living bone attaches directly to a load-bearing surface. When an implant is forcefully driven into jaw, it must remain absolutely stationary for that structural connection to establish. Living bone has an exceptionally low tolerance for movement. If functional forces shift the implant by more than a microscopic threshold of 50 to 100 microns, the delicate early vascular network tears. The body aborts the osseointegration process and isolates the implant with fibrous connective tissue, resulting in clinical failure. To prevent this micromotion, clinical training has historically focused on one primary benchmark, maximizing the insertion torque value or ITV. Achieving high mechanical friction between the titanium threads and the osteotomy wall is widely taught as absolute requirement to authorize immediate prosthetic loading. However, aggressive mechanical engagement inflicts biological trauma. When an implant is torqued into bone at forces exceeding 50 Newton centimeters, intense compression crushes the surrounding osteocytes. This extreme pressure creates local ischemia, starving the crystal bone of blood and triggering marginal tissue necrosis. Prioritizing high insertion torque sacrifices the health of the host tissue for immediate mechanical tightness. This approach routinely violates the biological limits of the bone, increasing the probability of early unpredictable implant failure. Total implant stability is not a static state. It evolves through two distinct phases. The first is primary stability. This is a purely mechanical phenomenon determined by the physical friction generated the exact moment the implant is screwed into bone. The second phase is the secondary stability. This is the biological integration of the implant achieved slowly over time through osteogenesis, angiogenesis, and mineralization of new bone matrix directly onto the titanium surface. This graph illustrates the temporal relationship between two phases. Primary mechanical stability steadily declines after surgery, while secondary biological stability takes time to develop. Their intersection creates a temporary valley of vulnerability between second and fourth weeks, known as stability dip. The initial drop in mechanical stability is driven by cellular remodeling. Responding to surgical trauma, osteoclasts clear away the damaged compressed bone immediately surrounding the implant threads. As this necrotic bone is resolved, the initial frictional grip loosens. Simultaneously, a delayed cellular response begins. Osteogenic cells are recruited to the site, differentiating into osteoblasts and secreting new mineralized matrix directly on the implant's microtopography. This gradual biological interlocking eventually replaces the lost mechanical friction. The timing of stability dip represents a severe clinical hazard. If functional chewing forces are applied during this 2 to 4 week window, mechanical friction is at its lowest and biological fixation is still too weak to offer structural support. The risk of exceeding the 150 micron micromotion threshold is at its absolute peak. Surviving this period of vulnerability requires abandoning the static assumption at day zero, mechanical tightness guarantees long term success. Success depends entirely on measuring and respecting the timeline of biological fusion. Despite the complexity of bone remodeling, many immediate loading decisions are still based entirely on surgeon's subjective tactile perception. Clinicians routinely judge bone density and subsequently authorize loading protocols based on how bone feels against the drill during osteotomy preparation. A recent MDPI clinical study tested the validity of this practice. Researchers compared surgeons' subjective tactile assessment of bone density against objective pre-operative measurements taken via cone beam computed tomography or CBCT. This scatter plot reveals a massive discrepancy between the perceived bone hardness and actual density. Tactile sensation frequently fail to correlate with the objective Hounsfield units measuring the true mineral density of the jaw. Tactile feedback is easily manipulated by external variables. Specific drilling protocols, aggressive thread pitches, and macroscopic shape of the implant itself artificially alters the resistance transport to the surgeon's hand, creating an illusion of tennis bone where no bone exists. Basing an immediate loading decision on the tactile resistance of a drill bit is statistically unsound. It relies on mechanical illusion that exposes the implant to high risk of biological failure. Similar to the tactile illusion, insertion torque is broadly misunderstood. Clinical guidelines heavily promote an insertion torque value greater than 35 Newton centimeters as the definitive green light for immediate provisionalization. Insertion torque only measures rotational friction, but functional mastication generates vertical and lateral forces against the ground. Rotational resistance offers no insight into withstanding these off-axis compressive loads. Furthermore, excessive tightening to achieve high torque guarantees pressure-induced ischemia, undermining secondary stability. High insertion torque is a one-dimensional single-time point metric. It measures how tightly the implant is wedged into the bone on day zero, but falsely equates that rotational tightness with long-term functional readiness. The obsession with initial tightness has heavily influenced modern implant design. Industry consensus dictates that conical or tapered implants are superior choice, particularly when working in soft porous bone classified as type 3 or 4. The mechanical logic is straightforward. A conical shape acts like a wedge. As it advances, it laterally condenses the surrounding trabecular bone, forcibly compacting the tissue to artificially spike the insertion torque. However, clinical data tracking actual biological stability tells a different counterintuitive story regarding cylindrical parallel walled implants. This chart compares objective primary stability. Cylindrical implants achieved significantly higher baseline stability than the conical group at day zero. Furthermore, month 3 follow-up data demonstrates that cylindrical implants maintained significantly higher secondary stability as they transitioned out of the stability dip. Conical designs provide high tactile resistance by crushing adjacent bone, while cylindrical implants engage host bone with less compressive trauma. By preserving the local microvasculature, the cylindrical geometry facilitates a faster, more robust osteogenic response. Implant selection must prioritize objective biological outcomes and secondary stability metrics. Chasing the immediate mechanical satisfaction of high insertion torque through aggressive macro designs often yields inferior long-term integration. To safely navigate this stability dip, clinicians require a measurement tool that is non-invasive, completely objective, and capable of being repeated across multiple weeks without disrupting the fragile healing interface. RFA provides this capability. By attaching a small magnetic smart peg to the implant and pulsing it with electromagnetic waves, RFA measures the implant's lateral micromobility, outputting an objective implant stability coefficient from 1 to 100. This scale outlines strict biologically validated thresholds. An ISQ over 70 confirms high stability, authorizing immediate functional load. Values between 60 and 69 require close monitoring and delayed loading, while an ISQ under 60 demands a conventional two-stage surgical approach. Because it relies on electromagnetism rather than physical rotational force, RFA can be performed repeatedly. This allows the surgeon to continually monitor the implant as primary stability drops and secondary stability takes over. ISQ translates invisible microscopic processes of biological healing into actionable numerical data. It eliminates guesswork. This flowchart maps the required clinical protocol. On the day of surgery, clinicians must abandon subjective tactile feel. Instead, they objectively classify bone quality using CPCT imaging, place the implant, and record a baseline ISQ measurement. If the baseline ISQ registers above 70, the implant exhibits high lateral stability necessary to withstand immediate provisionalization and functional loading. If measurement falls into marginal 60 to 69 range, loading is strictly prohibited. The clinician must wait and measure again during critical stability dip at the week 3 or 4. In a typical scenario, an initially marginal implant will experience a drop in ISQ at week 2, but as biological remodeling accelerates, ISQ recovers. Once longitudinal tracking confirms the value climbs past 70 threshold, early loading is safely authorized. Modern implantology demands a rigorous calibration of clinical habitus. Surgeons must replace the subjective assumptions of tactile feel and insertion torque with a continuous objective tracking of actual tissue integration. True clinical predictability and long term survival of the implant are achieved only when a rigid mechanical benchmarks yield to the objective realities of biological healing.